So I'll kind of stoop a bit. I don't have a vertebral fracture. I know this slide is familiar to most of us, that globally cervical cancer is the second most common cancer overall, contributing to more than 500,000 new cases and over 300,000 deaths annually. Notably, most of these cases occur in Africa and other low and middle income countries. By this I mean Africa, some parts of Asia, Caribbean, and Latin America. In Kenya, it's the second leading cause of cancer deaths. It contributes to around 10% of all cancer deaths. And this has been revised further that currently we have like 6,000 new cases, and out of which 3,000 deaths occur from cervical cancer. Why are we talking about HIV, HPV, and cervical cancer? This is because cervical cancer diagnosed in a woman living with HIV is actually an AIDS-defining illness. Persons living with HIV have been shown to have a higher rates of HPV infections and are likely to be infected with a higher risk types of HPV, and not just the higher risk type, but also multiple types of HPV than HIV-negative individuals. And therefore, women living with HIV are at 4 to 5 times risk of developing cervical cancer. Notably is that women with HIV are far less likely to clear HPV, mainly because the development of cervical cancer is actually as a result of persistence of the HPV infection. So screening is important because we now know that with the countries that have eliminated, have upgraded, or rather have very robust screening programs. And I'm going to just look at our local screening and try to see where we can place it. So this is an excerpt from our National Cancer Control Program. And it just looks into the fact that we are moving towards the 70-90 strategy of the WHO, whereby we're now zeroing on the 70, whereby our women should be screened with a high-performance test. So I'm going to look into the specifics as to what are the changes that affect the HIV-positive women. As I already alluded to the fact that we are moving towards a high-performance test, you can see from the left side of the screen of my screen is that for HIV-positive women, if you do a HPV test, for those who are not infected, you screen after 5 years. But for those who are HIV positive, you reduce that frequency to every 2 years. As we know that the screening with HPV is usually an entry point to colposcopy. So if you perform a colposcopy, if the woman is HIV negative, you rescreen every 3 years. But if for HIV positive, you rescreen every year. That is for colposcopy. There is not much change with regards to single visit approach screening with VIA and VILI. So the screening approach is based on patient risk assessment and the risk for progression. And this is just to reiterate what I've spoken about earlier, that the risk for progression of cervical cancer in women with HIV is a little bit higher. That's why the screening intervals has been reduced. There has been a question as to which the best screening modality for our population. We know that the WHO is recommending the use of, the HPV high performance test, but we know that this has a lot of resource constraints. And most of the facilities are still performing the single visit approach screening with visual inspection with acetic acid and Lugol's iodine. And this study was performed by quite a number of my colleagues from Western Kenya. And they are looking at whether screening with VIA is still comparable with HPV. And actually, the results are very impressive. And this was in line with other meta-analyses that were performed, which also showed that screening women with VIA has a better, can also detect the pre-malignant conditions of the cervix, as well as the HPV and other screening modalities. So now this brings me to management of the pre-malignant conditions. Usually there is really no much difference of managing cervical cancer in HIV positive and HIV negative individuals. But we have to contend of some unique features that we see in our patients. One of them is low platelet counts in patients with HIV, and this tends to delay our interventions. And also there are issues about prolonged hospital stay and also presence of, post-surgical infection, also known as the surgical site infections in patients with HIV. So just to go back to my slide now, there's not much difference in management of both of those two populations, but just to reiterate that there are two main modalities of management. We have got the ablative techniques and also the excision techniques. The ablative techniques means, for those who don't understand, it's like kind of to destroy the pre-malignant cells, either by freezing, that's cryotherapy, or laser or electrofulguration. But for, it's moved too fast. How do I go back? Yeah, so usually we have two modalities. Okay, I've mentioned about the ablative techniques, but there's also excision techniques. Excision means you kind of cut out or remove that part of the cervix that is affected by the pre-malignant disease. And there are two main methods. We use what we call LEEP. LEEP means loop electrosurgical excision procedure, or cold knife conization. I have a bias towards excision procedures. And why do I have a bias for this? Is because you will have a tissue that can be examined by the pathologist to look at the margins and whether you actually excised, as opposed to the ablative techniques, whereby you treat and the patient goes home and you are not really sure whether the treatment was effective. There's a role of hysterectomy, which means removal of the uterus, only in patients who have got recurrent pre-malignant conditions of the cervix. Stuck. Yeah. Now we move to management of early stage cervical cancer. And early stage cervical cancer seems I'm stuck again. Okay. Yeah, early stage cervical cancer is there are two main stages. We call it the microinvasive disease. This means that the invasion of the disease is less than 5 millimeters. And in this kind of patients, you can actually just do, depending on the fertility desires, you can do a conization, or cutting out piece of the cervix is also known as a trachelectomy. Then once a disease is a bit advanced, this stage 1A2 and 1B1, 1A2 means the invasion is up to 3 millimeters, and 1B1 means that when you examine the cervix, then you can be able to see at least a lesion or an ulceration. And in this particular patient, what is recommended is that you do a hysterectomy, but you do a little bit extended in that you remove the supports of the uterus. This is what we call the removal of the parametria. So this is just a summary of the options of treatment for the early cervical cancer. We've talked about conization, and then trachelectomy means just removal of the cervix, and hysterectomy, which can be either simple, depending on the extent of the disease, or radical, if it is a little bit advanced. Then we look at if the disease is a little bit advanced in terms of the size. There has been a debate whether we should do surgery or we should do radiotherapy in these patients. A lot has been talked about the effects of menopause on women, especially if you remove the ovaries. And personally, or most of us are now leaning towards surgical options in this stage of patients, because you're going to preserve the ovary and going to preserve the ovarian function, and that saves them a lot from bone density loss, amongst others. If you go for the radiation option route, that means that there's a very high risk of menopause, because there's almost always damage or effect on the ovary from the radiation. Now, seems that my slide said for a number of issues. I push again. Not responding. Yeah, so
Are you able to advance Dr. Odongo Elly's slides from the back? No.
Yeah, so the next slide I was going to talk about the locally advanced cervical cancer. These are cancers that are not amenable to surgery. We usually recommend the treatment using concurrent chemoradiation. This means that you give chemotherapy and also radiation therapy. There has been a consideration for a bit of altering the treatment of this stage of patients, especially in low and middle income countries, whereby the access to radiation may not be so widespread. And one of the ways is maybe to try and reduce the tumor size with the chemotherapy, and then you do the surgery when the tumor size is a little bit reduced. I don't have luxury of my slides, but I think that was the final slide. Thank you very much.